was so tired she had to stay in bed. Cystic fibrosis, cystic fibrosis. I wish she had roses instead. Cystic fibrosis, cystic fibrosis. I wish that she could come out to play.
Well, thank you all for being here today. I'll go ahead and get started. It's been about 2019 since I did the last talk on this, I think early 2019. There are a couple of updates. More so, there's a lot of new frontiers in this area. It's close to my heart, and the fellows have worked with me on these patients, both in the inpatient and outpatient area. And I always dedicate the talk to someone or a group. And at this time, I wanted to dedicate it to the families of the CF patients and the providers, in particular, Kayveris, who is not with us anymore. She passed away 3 years ago, but to her and particularly to all the nurses, as we all know, we're going through a major nursing crisis, and I appreciate all our nurses, our nurse practitioners, our mid-level providers, nutritionists, who have tirelessly worked with us during the pandemic. With that, I'll get started, and I have no conflicts. And I just wanted to talk about the pathophysiology of the CFTR gene mutations and how they relate to the advances in CF therapeutics, because it's always quite fascinating, this area, because this is one particular area where the medicine matches the mutation. So it is very, this gene in particular is very interesting, and we have made a lot of progress over the last few years. And also talk a little bit about the spectrum of CF-related dysglycemia. I use that word because it's not all related to diabetes. There is some other spectrum of conditions, and by itself, it could be a talk or more. However, I just wanted to do an overview just so that since we have fellows and a new group of CF providers, so I just thought it would be helpful. And also talk about some of the other endocrinopathies that go with CF. As always, we start with a case, 34-year-old female with Delta 508 mutation, and age 3. Age 3 was when she was diagnosed. She was diagnosed CF-related diabetes since 8th grade, and she graduated from the pediatric. And this is one classic case where pediatrics follows and they hand over to us, the adults, and there's a transition, and patients do quite well over time as they progress to their different phases of their life. And she has had oligomenorrhea. She desires fertility. She has history of PCOS, and A1C has ranged between 6.5 to 7.5% on pump therapy. And more recently, she's on this new medication, which is one of the major advances we've had in the field, which started right before the pandemic. So it started off with kind of going over a definition and some information on CF. It's the most common lethal genetic disease in North America. Approximately 32,000 Americans live with CF, and it's autosomal recessive inheritance, and 1 out of 20 to 25 Caucasians are carriers. And the etiology is the unique mutation in this chloride channel, the CFTR, which is the cystic fibrosis transmembrane conductance regulator. And the gene was identified in 1989. I'll talk about it in a minute. And it's the most common mutation that results from a deletion of the phenylalanine at the amino acid position, 508. And there's about, the most common one is the 508, but there's about 1,900 different mutations. And there's about 5 classes of the mutations. And despite all the progress that's been made, identification of the gene over the last 20 years, CF patients certainly suffer from a lot of the comorbidities. So it's important that we make more progress and research and everything else. Historically, CF was described early on by Dr. Dorothy Anderson, who published the CF of the pancreas and its relation to the celiac disease, clinical pathological study in the American Journal of Diseases of Children. So the first, female physician who described this pancreatic CF. And then she also hypothesized that it's a recessive disease and used pancreatic enzyme replacement, which we still do, and to treat the affected children. And as I mentioned earlier, 1989 was the major breakthrough with Dr. Francis Collins, who recently retired from the NIH as the head, and along with Jack Riordan, where they cloned the CFTR mutation, especially the most common one, which is the Delta 508. And this is this mutation, as I mentioned earlier, there's a deletion in many of the CF patients. It is the ABC transporter family, the Delta 508, and then it results in the loss of the amino acid phenylalanine in the 508's position. That's why it's called phenylalanine 508. And it accounts for about 2/3 of the CF cases worldwide and 90% in the United States. But there's about 1,400 other mutations also present, and it's a 50,000-year-old mutation. And I think it is in chromosome 7. Yes, it's chromosome 7. So that's about the CF mutation. I embedded a YouTube video, but then I said there's too much video, so I didn't. But it will be in the recording. That's about a very beautiful video looking at the actual depiction of the chloride channels, the epithelial sodium channels, and how each mutation happens, the trafficking, the sense, and how it comes to the epithelial surface. It's very beautiful. It's about 8 minutes, so feel free to watch it when you have a few minutes. So what is the role of the CFTR or the channels, the chloride channels? In the healthy airways, the CFTR is expressed, it's right here. And along with the enase or the epithelial sodium channels, the CFTR channel, it helps with mucociliary clearance in the apical surface of the airway epithelial cells. And there's a coordinated regulation between the CFTR and the epithelial sodium channels, which enables the proper kind of surface hydration and clearance of the secretions. However, when there's a mutation, what happens is that many of these patients end up there's a different molecular mechanisms, as I'll show you, and many of them end up having either there's a splicing, as we see here, or there's missense. I think this is the one with the so the missense mutation. Also, sometimes there's nonsense or splicing mutation, which they stop the production of CF. I think this is the most common one with the Delta 508. And then there's also other mutations, such as the trafficking and also complete stopping of the secretion of these channels. So there's retention in the endoplasmic reticulum and then subsequent degradation by the proteasome. And also the other, here's the classification. So normal CFTR, completely mature functional CFTR, is column number 1. It is in the surface from the endoplasmic reticulum, and the chloride as a chloride channel, and there's a tight regulation between that and the epithelial sodium channels. However, the class 1 is where there is no functional protein at all, as I mentioned earlier, and that is one of the severe forms. It's complete absence of synthesis of this, and there's no transportation at all. Class 2 is the most common one, like I mentioned, 508 deletion, and there's a reduced or intracellular trafficking of the CFTR, and it's retained in the endoplasmic reticulum. Class 3 is in the cell surface, but it's quite defective. It gets there, but it doesn't work as well. And like I mentioned earlier, class 3 is the most common. Then class 2 is the most common. Class 4 is where there is it's expressed in the cell surface, but it's insufficient quantity, so there's defective transportation. And class 5 is, it's abnormal pores in class 4, and class 5 is defective, inadequate quantity, and class 6 is also mild, which is it is present but it's unstable, so impaired transportation. So the first three, 1, 2, 3 are pretty severe, and 2, as I mentioned, is the most common mutations. So what are the structural airway abnormalities that you see? So just to know about this, we had to use the animal models, and the most common animal models which express CFTR when we do a knockout with complete full presentation similar to a human is actually the porcine model and the ferret model. The mice model do not, they have the lung, but they don't have the other things that you see, such as the skeletal changes, liver changes, pancreas changes. Only the ferret and the pork model or the pig model have the complete changes as you see in the human, and these models are in the University of Iowa lab, and which is where most of the studies have been done. This first area shows the non-CF patient with the tracheal areas, the laryngeal and upper tracheal areas, and it's about 6 to 8 week old. This is actually a mouse model. But the second one, panel B, is actually a pig model, shows the non-CF patient or pig and the CF knockout pig, and that shows newborn pigs actually. And then this is sinuses in the upper airway, sinuses in non-CF and CF pigs. And as you can see, the maxillary sinus, okay, but the ethmoid, which is in red, is very underdeveloped in the pigs. And this is as soon as they're born, in the newborn. And it's a 3-dimensional view, and it's hypoplastic ethmoid sinuses. And then this shows the chest CT of a newborn pig, the day it was born, actually, at the day of birth. And it shows the airway trapping and mucus obstruction, air trapping, which is sign. And of course, here's the human model of cystic fibrosis from a 14-month-old, showing exactly the same thing with the mucus plugging and the air trapping. And this, so that kind of shows us how severe this illness is. And the CF registries are globally present, while it's most common in North America. You've seen it as much as in other countries in Europe, and even in India, in the Kashmir area, and in the south, there are a few cases. So it's prevalent pretty much everywhere, but most majority of it is in the continent here, North America. So in terms of the foundation has a beautiful registry that you can go in and pull data and look at, do studies and look at a lot of different data. And this is the most recent one from 2020, and that shows us the number of current patients with CF, which is 31,000. This is the North American CF registry. However, 3 years ago, when I pulled the data from 2016, it was 33,000 at that time. So, and newly diagnosed, and median age at diagnosis is usually 3 months. And what I wanted to bring your attention is adults over 18 years. There's about 57% of the patients now are adults over 18 years, and that's where we come in, and it's very important. Race distribution, 93% Caucasian. However, we do, I personally take care of 2 or 3 African American patients. One has moved, but we do have 2 African American patients, and Hispanics, any race, 9.6, other races also. And the male-female split is about 50-50. You may ask, among adults and children, how many adults and children? There's about 50% under 18, 50% over 18. And that was pretty much kind of looking at where we are interested in. In terms of how things have progressed with CF over time, it's very fascinating history. In median predicted age of survival in 1950 in many of these patients was under 10 years. And if you look at kind of the history of what has developed, sweat chloride test for checking for CF was developed somewhere in the 50s, and then antibiotics for CF pathogen, airway clearance, pancreatic enzymes, and then moving on to TOBI And then most recently, and these are more advanced antibiotics, in 1989, CFTR was discovered. CF care centers were established in about late 1970s. And then 2010 is when the first medication which matches the mutation was produced. And fast forward 10 years, 2019 was a very fascinating new drug that was produced. And when you look at the survival, that kind of goes along with the progress that's been made. And we go by 5 years and map the survivals from 88. So if you were born at that age, what was your survival, in the future? So somebody who's born at between 2016 and 2020, which now with the newer medications, their survival is almost over 50 years. And that, as you can see, is a beautifully advanced in terms of predicting survival. So in terms of, I think we already went through this, so I missed this part. Drug development, we talked about how the mutations match the medication. So I'll go on into the different mutations that are present. I know, sorry for the typo here. So the kind of the print is small, but the most common one, like I said, 85% is the 508, but there are several other mutations, and sometimes there's duplicate mutations. But however, the most common is the 508, and which is where the most of the focus for the medications are. So early on, like I said, in 2010 was the first medication which matches the mutation was available, and it was ivacaftor, and then later on lumacaftor, ivacaftor, which is two drugs combination, and then tezacaftor with ivacaftor, and these are for correcting the CFTR defect, which is underlying, which is the gating defect, gating mutations. However, the most recent one, which was major breakthrough about 3 years ago in October, a few months before we went into the pandemic, was this new drug. It's called Trikafta, which you can see it in our medication list of most of our patients, which is a combination of 3 drugs, elexacaftor, ivacaftor, and tezacaftor. And it is again for F508 deletion. And early on, when they first, 3 years ago when I presented the data, it was only for over 12 years old, but over the last 3 years, it's been approved over 6 years, unless our pulmonologists say if they have a better update than what I've seen. So, and why are we involved? Why is endocrinology involved? Well, the most important reason I'm going to present here, which is, CF, how it affects the whole body from head to toe. Airways, we looked at it. Liver, important area, cirrhosis and liver disease with gallbladder. They have what is called as a micro gallbladder. Pancreas, exocrine, and endocrine, obstruction of the ducts, ductal obstruction, and meconium. Many of them are born and within a few months have meconium ileus and go on many times to have bowel obstruction frequently. And reproductive tract, infertility, both hypogonadism and issues with reproduction, and vas deferens atresia, and chloride channel or sweat chloride test is how they diagnose. So that's your sweat gland issues, and CF bone disease, which fellows are very, very familiar with, and kidney stones, of course. And more recently, something very important that we're involved in, and that is aging. As they're all living past their 50s, we're talking about screening for other issues, talking about menopause, and going over some of the good things that we talk about as patients age. So complications of CF, which is most common complication, as you can see here, is about 18% overall, and about 30% in the adults is the CF-related diabetes, and which is where we are quite involved. And the hepatobiliary complications overall as liver disease come next. The next area of interest for us is osteoporosis. About 4%, 7% in the adults. Osteopenia is more common. Almost about 1 in 5 of our adult patients have osteopenia. And of course, fractures. And as I mentioned, because of the breathing and the thoracic cavity, it's very important to not miss rib fractures or vertebral fractures. So it is a very important area. And of course, all other non-endocrine complications, which could be pretty severe in these patients. So as I mentioned earlier, most of the complications, most common complications are mostly in the adult life, and they progress, especially CFRD, which I'm going to focus on as they go into their 20s and 30s. And this is the most recent registry data from 2020, and this is all patients, gray is all individuals from the age of under 1 to 70. And the blue is the actual patients diagnosed with CFRD, and the red is the impaired glucose tolerance. And as you can see, as they hit their 20s, there's quite a significant rise in the CFRD, many of the patients, and the impaired glucose tolerance also progresses over time. And almost in children, many children, and this is a study from almost 1999, I think, yeah, 99, by Tony Moran, who's one of the very well-known CF endocrinologists from Minnesota, where they have a huge CF center. And if you look at age groups in quartiles, or 5 to 9 years, 10 to 19, 20 to 29, and 30 plus, you could see that the dotted areas are normal glucose tolerance test, dark areas impaired glucose, and the clear areas is CFRD. So the CFRD, they already over time start having impaired glucose tolerance, and by the time they get to the age of 20s and 30s, there's a higher incidence of developing from impaired to CFRD. So what are the determinants of cystic fibrosis-related diabetes? Well, as we already looked at age, as they go through every decade, there's a higher risk. Women seem to be at a higher risk compared to men for cystic fibrosis-related diabetes. And worse the FEV1, higher the chance, which we don't know if the diabetes causes the lower FEV1. And many times when the FEV1 is low, you start suspecting they do have diabetes or impaired glucose tolerance, for which they get screened. And any liver dysfunction, as we all have seen a lot of patients with cirrhosis, liver dysfunction can lead on to insulin, to diabetes or impaired glucose tolerance. And if patients are already using prion or pancreatic enzymes, naturally from exocrine, they can also have endocrine. And also steroid use, which temporarily some patients go on steroids, go on insulin, and then they come out of it. CFTR classes, the 1 and 2, the most severe classes, have a higher risk compared to 3, 4, 5, which are milder classes. And so that is kind of risk factors. Now, where did we learn about, like I mentioned earlier, most of what we know about the pancreas, the lung, comes from our animal models, the pig and the ferret models here in the lab. And if you, this is where I kind of overlap with what Dr. Mokshiganam does with the ILID program, because we're going to talk about what is the different pathophysiology and why we have CFRDs. It's not one hit hypothesis. There are multiple things that happen, such as the beta cell CFTR mutation, which I'll show in a minute, alpha cell mutation, type 2 diabetes genes. Now we know that certain genes like the TCF7L2, which is a common type 2 diabetes gene, and the CAPN10, and all which are involved in beta cell proliferation and insulin secretion. Those patients who have the gene mutation have a higher incidence of cystic fibrosis. And also those patients who have family history of type 2, like one that we saw this Monday, I think Daniel was with me, a new patient. He had a family history of type 2 diabetes among several family members. He was also on atypical antipsychotics. That was the other reason. So the A1C was quite high at presentation. And also certain other susceptibility alleles for type 2 diabetes, such as the SLC26A9, CDK, and CDKN2 series, and IGF-BP2 also. They seem to have a higher susceptibility. And also other insulin insufficiency, insulin resistance many times, related to steroids, to infection, and undernutrition. And also there may be deficient incretin signaling. It has been shown that patients with CFRD or CF impaired glucose tolerance do have decreased GLP-1 production, thereby causing decreased insulin secretion. And of course, exocrine pancreatic insufficiency, ductal obstruction can also lead to it. So it's a very kind of complex phenomena with a reduction in the beta cell mass many times, so reduced insulin secretion and thicker secretions in the pancreas causing the blockade. And apart from that, also, like I mentioned, lower incretins production and increased insulin clearance can also cause this. And the other area, other concern or other studies that have shown also islet amyloid deposition has been noted. And there's also a very interesting study looking at vasculature from the Seattle CF group where they showed the capillaries are affected, capillaries supplying the islets are affected. They've done a very beautiful study recently presented. This is a pancreatic duct obstruction in a newborn or a 6-month-old CF pig model. And as I mentioned earlier, this is another study from another section from a 16-year-old CF patient's pancreas. As you can see, there's grouped islets and they're surrounded by fibrotic tissue and fat saponification. And it shows that, it's called mucoviscidosis. That is one of the things. And this is a ferret model pancreas from newborn all the way to day 32, showing average inflammation score in the CF knockout ferrets as compared to non-CF ferrets. And as you can see, there's increasing inflammation scores in the ferret model as soon as the day it was born all the way to day 32. So this starts right before birth. And as I mentioned earlier, the beta cell also has some abnormalities with the CFTR channel, a CFTR mutation causing difficulties with the insulin secretion. As you can see, this is a normal beta cell versus a CFTR beta cell. So those are some of the interesting kind of hypotheses. I mentioned the capillary or the vasculature. That showed that the study showed there that the pancreatic ductal epithelial cells have higher destruction and fibrosis, so it causes lower capillaries and higher inflammatory cytokines and decreased insulin secretion and also apoptosis along with that. How does this affect the lungs? Well, this other interesting study from the pulmonary group, and I can't recall right now which group it is, but they looked at, I think Prentice from Europe, they looked at the airway surface liquid and looked at glucose homeostasis. Very interesting there. This is a normal airway and with normal intact CFTR, GLUT transporter here, very minimum amount of glucose, the triangular areas of glucose, and it's very tightly regulated glucose gradient in health. However, when there's a CFTR mutation, what happens is there's upregulation of the GLUT transporters and there's dysfunctional junction, so there's leak of glucose into it and net increase in the transfer of the glucose, causing in CFRD patients when the glucose levels are higher, and that increases their risk for infection and everything. So in a way, patients with cystic fibrosis who have, the glucose levels can cause higher lung inflammation and lower FEV1, which has been well known. There's a connection between hospitalizations, FEV, mortality, and everything with CFRD. So it is the loss of lung function becomes a key component of decline, because that's where that kind of puts them in the hospital, often CF exacerbations. And one area where there's a lot of recent interest in the change in gut microbiome also in the CF patients, and of course, inflammation. So it's kind of a cycle that leads to declining lung volume. So how do you screen these patients? So anybody over the age of 10 years, I know we are kind of going lower and lower. It used to be 14 years and then 10. We may be even going lower than that, depending on our risk factors and everything. Some centers do recommend doing 6 years. And usually we do a 1.75 gram per kilogram or a 75 gram glucose tolerance because we all know, and it comes in the boards for the fellows, A1C underestimates diagnosis of cystic fibrosis related diabetes. You can use it for treatment, follow-up, but you cannot use it for diagnosis because you always underdiagnose CF. If somebody has a A1C over 6.5%, we could kind of say yes, they probably have it. But if they have normal A1C, that doesn't rule out CF, and that's very important. We do not use A1C overall. We do use the oral glucose tolerance test, weight-based or 75 gram. However, more recently, we are looking into a lot of technology because there's been very elegant studies that showed wide fluctuations in the sugars, even in normal glycemic youth with CF, has been linked to any lung function abnormalities and lung function decline and other comorbidities. So it has been validated. However, we need more studies to start using a CGM area under the curve or time and range to say somebody has diabetes. But the work is in progress, and we should have some results pretty soon. So what are your diagnoses for CF? It is sort of similar to your adult type 2 diabetes patients that we see. Fasting glucose is, normal glucose is 100. And if they're impaired, they could be anywhere between 100 to 126. And impaired fasting glucose, and of course, impaired glucose tolerance over 126, or if 2-hour time point could be anywhere between 140 to 200. And indeterminate glycemia, that is index, is less than 126, but their 1 hour is high. This was a study that came on, I think, when I was a fellow, like long time ago. It was very interesting, the 1 hour glucose tolerance being higher, even though the 2 hour was less than 140, predicted, future CFRD, and also sometimes was linked to lower FEV1. So now we start paying attention to the 1 hour glucose tolerance many times. And CFRD, of course, over 126 and 2 hours over 200. So that is similar to our normal patients, except this index is a little different. And we do focus a lot on IFG and IGF because they can quickly progress to diabetes. What are some of the other criteria? Because you don't see them, CF patients are not your regular healthy patients. They walk in fasting and they can do it. Many times you end up seeing them in the hospital, or you see them right after their hospitalization as a thought. Well, if they're during hospitalization, we do use the glucose levels of over 126 and over 200. If persistently for more than 2 days, patient woke up with over 120s, or their random blood sugars or postprandial is over 200 for 2 days in a row, then you could easily make a diagnosis of CFRD in the inpatient who previously didn't have the diagnosis. And also during enteral feeds, some of them are on continuous tube feeds, which is a common thing that we have to do with CF patients because nutrition is a big issue. If they have post-feed or mid-feed is over 200 in 2 separate nights, then that also confirms CFRD. A1C I mentioned, if it's high, then it is CFRD, but if it's low or normal, it does not rule out. And any random glucose of 200 or over 200 with polyuria, polydipsia is certainly CFRD. So, and I mentioned this already earlier. So reactive hypoglycemia, which is a small group of patients that we see quite often, and about 29% who undergo the oral glucose tolerance can develop a reactive hypoglycemia. And many times we also wonder, should we do a mixed meal like we do for the islet transplant patients, because the load is so high. In adults, we don't go by per kilograms per, for giving the glucose like we do with the children. So perhaps that's something to consider. So this is mostly seen in patients who are delayed first phase insulin release and many times irrelevant kind of poorly timed second phase and the glucagon response, which I forgot to mention earlier. In the CF RD pathophysiology, kind of a dysregulated glucagon phenomena occurs or happens along with alpha cell dysregulation. So that's very important also in the CF pathology. So let's see. What are the complications in CF diabetes? Well, majority of, unlike the adults, it's not as high, these numbers here, but we do pay attention because many of them, especially the women with microalbuminuria, especially if they plan pregnancy, we worry about eclampsia and other issues. So there is some microalbuminuria, there is some retinopathy, and renal insufficiency happens, especially those that undergo transplant or have underlying other diseases, and then neuropathy is there, and many times it could be related to some of the medications. One of the bigger concerns is actually hypoglycemia, because the BMI is so low in many of these patients, and as you will see, insulin is the most common treatment. So hypoglycemia is a big issue, and that's where the technology, sensors, and CGM are very helpful in these patients. I have already reiterated that diabetes is one of the the attributes, a highest risk factor for CF performance over time. And this is just a study looking at that area with 17,000 patient year follow-up, and where 300 patients died. And the biggest or the underlying issue or the confounding biggest factor was diabetes, and along with the Burgdorfia cepaceae, which is a certain bug. And this is a study from a few years ago, and also organ transplantation. So diabetes is one of important comorbidities and increases mortality, especially a CF patient, female with diabetes is the highest risk. So that's very important. So once they're diagnosed with CFRD, well, immediately as we have a kind of a multidisciplinary center, we have great nutritionists, both in our diabetes center and also in the CF center. They're excellent. And going over diet is one of the key things, because the diet in CF is slightly different from what you tell a type 2 diabetic, where you go, say, you cut your calories, you do this. Here we are giving them 120% to 150% of recommended daily allowance, because of, they need to maintain their body weight, their BMI, which I'll go in a little bit and show you how it's slightly different in the last 2 years. Exercise, very important, which helps them with diabetes, minimizes insulin use, and also helps with their PFTs. And it's important. So what are the major differences between CFRD type 1 and type 2 management? Peak age of onset, like I mentioned earlier, young adults in type 2 and with CFRD, whereas in type 1, children and adolescents. Antibody status, extremely rare. I had one patient who had a type 1 presentation with CFRD, more like a type 1 diabetic, but there's a family history. Otherwise, antibody status is usually negative. Insulin secretion, I mentioned earlier, there's decrease because of the amyloidosis and the beta cell CFTR mutation. However, there's also resistance, especially if they're getting steroids and other issues. And sensitivity, again, is decreased. And treatment, the main treatment is insulin. But type 2, of course, we have a lot more options. And I'll kind of mention about other treatments that are available. Diet recommendation, high calorie. Sometimes we do move away from that depending on the BMI of the patient. Not too many macrovascular complications, unlike the other two. Certainly microvascular, microalbuminuria, retinopathy, CKD. And usually the cause of death here, unfortunately, is the primary organ, which is the lung, unlike the other two, where there's cardiovascular and nephropathy. So the treatment patterns, most of them, diet changes do help. That's why the dietitian's involvement is so important. And then 71% of the patients, it's insulin. A very small group actually go on oral glycemic agents, which I'll try to go over a few. Their average A1C, median A1C in the last 2 years, or 2020 when it was looked at, average A1C is actually better than what you see in the other groups, 6.5%. It's great. Unlike, I know last week we saw some higher A1Cs. The average in the clinic was probably double digits. Just two patients shifted the curve. How do you treat these patients? Well, in the interest of time, I won't go too much into the details, but the dosing of the insulin is very, because they're very sensitive. It's almost like zero point 0.5 units of, and these are patients where we get the junior pens where you can have 0.5 increment rather than 1 unit increment. And we try to use a carbohydrate ratio, if they're able to learn it, is 1 to 15 is what we use. And then the increase is also by 0.5 unit increments. This is both in children and in adults. The targets used are fasting 90 to 120 and bedtime 90 to 150. This is in non-gestational patients. Gestation is a little bit different. Of course, I won't go into the details of the nutrition, but I mentioned earlier the calories and the carbohydrates are much higher compared to what you would teach your other patients. So these are the various insulins, and this is a junior pen that I had just mentioned about, which goes by 0.5 unit increments, which are quite helpful. Of course, when there are enteral feeds, they get steroids, all that, we need to kind of adjust things for that. And what are the oral agents? There have been very small studies. There was one of the agents, which is the glinides, metaglinide. There was a small study. I didn't show the study here. It's a little bit older study, rapaglinide. And then GLP-1, there was 1 or 2 case reports, but not showed some improvement in the gastric emptying, but not in insulin secretion. So, however, there's one recent study just about 3 months ago in JCEM from the Pennsylvania UPenn Children's Hospital Group, Dr. Kelly and colleagues, looking at 6 months of DPP-4. This is in adults, not in children, with CFRD, about 26 patients, and looking at insulin secretion. And they did find some improvement with augmentation of the glucagon suppression. And also there was some improvement in meal-related insulin secretion dynamics. But it was just 6 months, and we don't know the long-term follow-up. But certainly sitagliptin has been in the news about this. And also there was a case report looking at 3 patients with sitagliptin. However, 2 of the 3 patients were transplant patients, so not necessarily the same group that we see. Once they get transplant, there are other issues that play in. And these patients were followed for 5 years with good control and were able to get off insulin. So there was one new study looking at SGLT1, not SGLT2, SGLT1, which is sotagliflozin. And it was a very interesting study looking in rabbits. And interestingly, there was some stress attenuation using SGLT1, and it upregulated SGLT1 is upregulated in the CF rabbit pancreas. So actually, there's some improvement in insulin resistance, and also in the lung. So that was just one small basic science study. So we still have a long way to go with SGLT1 or SGLT2. Apart from cystic fibrosis-related diabetics, we do see the patients who undergo lung and sometimes lung and liver transplant, and they develop post-transplant diabetes. They may not have had CFRD, but they do develop post-transplant diabetes. And as you can see here, the transplant in CF patients until 2018, it's almost doubled in the last 10 years or so, or 20 years or so. And these patients do go on calcineurin inhibitors, mTOR agents, glucocorticoids, and the resistance, because of insulin resistance, sometimes we have to go on treatment. So moving on to the new frontiers of good things that have happened in the last 3 years. This is just a sketch looking at patients in the CF centers. How many of them are college graduates, or at least some college, more than 60%, and almost 70-80% have gone through high school. You can imagine somebody who's sick has to start the day with inhalers, medications, all day. If you look at a day in a CF patients, just day to day, there's so much. And for these kids or adults to make any advances in life, finish high school, finish college, get a job, graduate from any degree. That is like a great accomplishment. It's like almost like getting a doctoral degree or a thesis. And many of them, more and more, we are seeing a lot of them married or living together. More than 50% of the adults are partners, and many of them are employed, many of them full-time. I have patients who do more than one or two jobs. Many of them are professionals, accountants, pharmacists. So it is amazing what they accomplish. So with that comes, good things in life, and one of them is CF pregnancy. Although we have permission, I did not want to, put the face of the patient. It's one of positive experiences seeing patients, and they have one child, and then came back, and we had, two children delivered under our care. So that was very good. So one good thing that's happened, which we see a lot of pandemic pregnancy, but interestingly in the CF centers, we saw an amazing increase in pregnancies, if you can see. Live pregnancies between 2015 and 2020. It's kind of exploded. In fact, the Ohio State, they said from 4% pre-pandemic, they went to 25%. And we ourselves, I think we had 4 pregnancies through the last 2 years. One of them was delivered elsewhere, but the other 3 were with us. So it has kind of increased how the way we look at things and looking at metrics for these patients. So one of the things with CF is even if they don't have previous cystic fibrosis-related diabetes, unlike your regular non-diabetic patients where your screening happens in about the second trimester, 24 to 28 weeks, in CF patients, you don't wait till they get to the second or third trimester. You start screening them from early on every trimester, almost like 12 to 16 weeks, first 2-hour GTT, then again in 24 to 28. And also 6 to 12 weeks postpartum to make sure that they didn't develop CFRD. Although that guideline is there in the adult non-diabetic gestational diabetes, not all patients follow it, but it's very important to remember there's a difference the way we screen patients who are non-diabetic CF patients when they plan on pregnancy. Also, there's a lot of pre-pregnancy counseling, apart from genetics, and then changing their medications. There are certain antibiotics you don't want these patients to stay on during pregnancy or before that, like tetracycline and all that related drugs. And also during pregnancy, there's so many changes with the decreased insulin sensitivity and secretion, increased hepatic gluconeogenesis, and risk for preeclampsia, pre-pregnancy counseling. Usually these patients are on high-dose vitamin A and CF vitamins, so you want to start them with a prenatal vitamin even before they plan pregnancy. Switch from 2 CF to 1 CF and 1 prenatal, of course, with discussion with the pulmonary or the CF attendings. So, and also, screening, like I mentioned, screening every trimester is also very important in these patients. So one of the other reasons that we are seeing higher pregnancy is because also patients are feeling much better than they did before, because that kind of fell along with the same time as the 2019 Trikafta, advent of Trikafta. So that, as I would show you next, there is an issue with metabolic syndrome from being underweight and low BMI. Now we go to overweight, and many of them feel so good that they start planning pregnancy and everything. So not going to go too much details into testosterone deficiency because that does exist in these patients. But I do want to mention, I know if Dr. Winter's in the talk, if I didn't mention the CB-AVD, he would not be happy. So it is a very interesting, aspect of CF, and many of these patients, 97% of them have atrophic seminal vesicles or the tail of the thymus, and many of them have azoospermia. And interestingly, you would see other patients who don't have the lung mutation or the pancreas and just have only this presenting as azoospermia, and it's important to remember to look for mutations in these patients. So in the functional CFTR, 100%, it's normal, but when it's 0 to 10%, you have everything affected, like the severe mutations. So, see if this works. Go to the bone now in the final few minutes. Good. Thank you, Eric. I wanted to thank Eric Borg, our ophthalmology resident, who helped me embed this, and also Kelly. I shouldn't forget Kelly. She helped, and her son also helped embed the music earlier. Thank you, Kelly and Nancy. So you saw that earlier. Do it again. The CFTR knockout or CF bone versus normal bone. You can already look at it and say there's something wrong with it. But CF bone disease or CFBD prevalence in the 2020 registry, just like CF-related diabetes, it progresses. There's a lot of osteopenia and osteoporosis, especially women as they live longer, go into their 50s and 60s. We're seeing the menopausal issues also. 38% of adults have T-scores, which is the osteopenia range 1 to 2.5. And or Z-scores also if they are under 45. And 23% have osteoporosis, or I shouldn't call it osteoporosis, they don't accrue the bone mass. So they have severe low bone mass where you need to start them on some medications or treatment. So, and it also correlates well with lower BMI, which we see even in osteoporosis. Lower the BMI, higher the risk of bone disease. Reduced FEV1, which again goes along with the rib and the musculature and all that. And in this case, men are at a slightly higher risk than women are. And main reason for that is also the testosterone deficiency, estrogen deficiency. So mentioned that already. And this is something important I wanted to highlight. I think I showed it to the house staff earlier today, is looking at vertebrae. Many times the bone density may look normal, but they may have wedge fractures in the back, in the spine, and many times broken ribs. So it's important to kind of stratify and pay attention to their back. So the bone by itself is a whole lecture in terms of the basic science of it, the CFTR, the channels, and the different bone turnover markers and everything. But I'll just kind of give a quick overview as how you optimize their bone health. Screening usually starts at the age of 18, but can start earlier if they have other risk factors present. And here we look at Z-scores, not T-score. And depending on the scores, we decide if they have to be screened every 2 to 4 years versus every year, especially if they're on treatment, especially if they're under 2, a negative 2.0, they go every year. And then if you want to maintain a BMI that's over 50th percentile, and in adults, over 22 and over 23, especially men are at higher risk. And of course, in men, we also screen them for hypogonadism, testosterone. We have a patient who had a traumatic brain injury and has actual central hypogonadotrophic hypogonadism. So and calcium intake, which everybody in the group is familiar with, and there's a pediatric and the adult. Vitamin D, I can repeat it like 100 times. Vitamin D and CF, because many times the absorption issues with D2 versus D3, and D is so important in several areas of CF, and you can't emphasize it enough times. And of course, vitamin K also in these patients because of their issues with the pancreatitis, exocrine pancreas dysfunction, and ADK deficiency. It was just one interesting study that I wanted to point out. I thought it was very interesting, especially because recently we have the newer anabolic romosozumab, or we call it romosozumab or Romo, which kind of sclerostin, anti-sclerostin antibody, but it kind of works through the Wnt beta-catenin signaling pathway. And this was a very interesting study looking at, not know which animal this was. I think it's mice, CFTR mice. They placed a magnesium rod inside the bone of these animals in the knockout and in regular patients in the regular wild type. And then you could see within a few weeks, I think almost 6 weeks later or something, there was new bone formation when the magnesium was in there. So their hypothesis is, in a way, magnesium helps with the defective CFTR channels in the bone, and improves bone function, or osteoblastogenesis. So improves the bone formation. So it was a very interesting thing, I thought. So BMI in the last 2 minutes, as you can see here, between and this is the percentile, and this is years since 2000 to 2020, men and women. This is the pediatric, and this is adult. Men in blue and women in red. And it has improved over time, all the way to almost 23, and that goes along with what I'm just going to show you, which is the green here, which is the Trikafta, the 3-drug combo regimen. Since 2019, we started using it, and now we're seeing a little bit of a metabolic syndrome in many of these patients. So this study here in the cohort in the University of Minnesota, 25% were overweight and 6% were obese. CF patients are obese. And also another European centers, 22% were classified as overweight or obese. And so it is now we are beginning to pay attention to that part, because the metabolic syndrome, then again with the diabetes. So, and it's actually a good problem to work with rather than the other way. So that is about metabolic syndrome, pregnancy, and the bone disease. And this was I said endocrinopathies. There was just 1 or 2 studies looking at the thyroid gland. Apparently in the pig thyroid gland, there was CFTR mutation present. So they do recommend screening these patients. We do get TSH in all of them. I'm yet to see somebody who's hypothyroid. Well, actually, I have 1 patient who's hypothyroid, but others are doing okay. And there's one nice review on adrenal function in CF, but this is mostly patients who have been on steroids for transplant or other purposes, long-term steroids. There's something about a 1 microgram stim test, which we do not do. We use the 250 for adrenal function, but this study talks about the 1 microgram. So just one interesting area I think we all need to know about. And in the islet program, I know there are 2 patients who had CFTR mutation, 2 ladies. So this is, the red is complete CF, the blue is CF, and then the red is the carriers. And these are the spectrum of CF issues. And this is a study which looked at the carriers, analyzed all the data, and it is very interesting how many of them, pancreatitis, isolated pancreatitis, isolated, other issues, respiratory failure, several other conditions. So it's very important when you see a patient where you cannot explain, but they don't have CF, it's very important that we do think, do they have a CFTR mutation can present this way. It was a very nice study that came out of the University of Iowa just recently by Stolz and group, and I thought it was very fascinating, with the mutation. So as these patients walk across the bridge from pediatric to adult, we as the adult endocrinologists have to kind of go through all these in the given time, the diabetes, pre-diabetes, hypoglycemia, CF bone disease, stone disease I didn't go into, fertility now, pre-gestation, pregnancy, postpartum, post-transplant diabetes, post-transplant bone disease, hypogonadism and fertility, and steroid-induced hyperglycemia, metabolic syndrome, which we are seeing more, and of course aging. With that, I wanted to close and wanted to thank everybody here and watching virtually. And I wanted to present the team of the CF Center here. Thank you, everybody in the CF Center. Thank you, Dr. Hagen and Dr. Ramirez, for letting us work with you all to help these patients. I will stop here and take any questions. I think somebody was asking me, why did you put 65 roses? I think many here may know the story behind it, but this is the 3 brothers, all 3 had CF, and this is from, I think, 70s or so. And the mom was trying to do fundraising over the phone, I think 60s or 70s. And then this 5-year-old Richard told mom, I know what you're doing. You're trying to make money for cystic fibrosis. He heard cystic fibrosis as cystic fibrosis. So since then, that kind of has been something. And the music that you heard early on is, from the Wolverines Australian band. It's, I think one of them sister has CF. So, and thank you all for your attention. And I'll take any questions here.
Do a lot of CTs and things like this. So, is there chronic calcification?
It's a great question. Dr. Mokshaganam wants to know, these patients do get a lot of CAT scans, lung CT, or any other abdomen, and he was asking if there's any coronary calcification in any of these patients. Not that I know of. I don't know if any of the CF pulmonologists are in the talk here. If they are, I'll ask them to answer that. I have not seen that. But I'll look up and let you know. Oh, I forgot to say the code here is for the talk, which I thought I had it in my talk, but I don't see it now. Is 1281582. 581,582. So, yeah, I'm not sure, Dr. Mokshaganam. That's one thing I didn't see is heart disease in this group. So everything microvascular. But I'm hoping as we're adding more decades to these patients that may be a good problem to have.
CFR, what about microalbuminuria? No.
So one area of interest was preeclampsia. The patient that I had who delivered did have preeclampsia, and she had microalbuminuria before. I had her on ACE at that time, and she said, I already have children. I can't identify too many details because there's so few of them. And I know this is watched virtually, but so left her on ACE. But then during pandemic, went on Trikafta, felt good. She was actually elderly, gravida, did get pregnant, but was able to see high risk OB. I wasn't involved because it was early on during pandemic, and had been to another center, and they changed the medications, and she did have preeclampsia and was delivered, but she's fine now. But certainly that is a concern. We have one patient who has kidney disease, but he also has liver disease and has, I think, has had a lung transplant. So that is related to that. So further beyond the microalbuminuria, I have not seen macro. Let me see. A few questions here. Try and answer them. So Dr. O'Hagan, the CF pulmonologist, says there are a few case reports of myocardial infarction in CF. I'm not aware of studies looking at calcium scoring. That would be a great project, though. So, and thank you, Swapna and Doris. Dr. Kotwal wants to know that CF with type 1 or type 2 gene defects. I think I presented the type 2 defects. Type 1, I'm not familiar with, but the type 2, I listed them earlier. We do have TCL7 and all that, but type 1 I haven't looked at. We did have one patient who had the antibody to type 1. Then Lika, CF, she does share her experience that she had her residency colleague with CF, did first year of rheumatology fellowship. Wow. Going through medicine, that would be the first CF patient. Thank you, Malika, for sharing that. I think those are the questions here that I have. Any other questions?
Is there any difference in the studies on the bone disease response to treatment?
So I didn't go into the bone at all, mainly because it's such a huge topic. So bisphosphonates is what we've been using. And since I brought up the pregnancy, many of the younger women trying to stay away from it because of the concern of the deposition and longitudinal impact on the children. So majority of them, many times it's using reproductive hormones, nutrition, and calcium and vitamin D seems to improve the bone density. And improving their exercise capacity many times does improve a little bit, most of it. But I was amazed at even 1998 annals, how many of these patients had high risk of fracture compared to their age group of patients. The twofold increase in fracture and vertebral fractures and low bone mass. So seems that using sex steroids can help improve it to some extent. Of course, many of them have major dental issues and everything, and giving them nutrition. In children, I'm not sure how they handle it, but at least in the adults, improving their nutrition, especially the European colleagues say when they use the nocturnal tube feeds, they do see much higher improvement. The Trikafta has done wonders for a lot of different things, and that is one area we're looking at. Any interested fellow or resident can look in because we have the data access is to look at bone mineral density in Trikafta patients because it is very interesting what we see with that. Certainly. Right. Thank you, everybody. Hi, Liz. Thank you. Oh, Scott. Thank you, Dr. Pickle. Okay. Thank you, everybody. Have a good evening.